Hello and welcome to another Frotan Academy video. Did you know that vitamin D not only strengthens your bones, but also regulates your immune system, boosts cardiovascular health, enhances mental well-being, and might even help prevent premature death? In this video, we will dive into how sunlight and diet contributes to vitamin D synthesis, explore its broad biological effects, and examine the rising prevalence of deficiency and its complications. We will also break down how laboratory tests using advanced methods like immunoassays and LC-MS help diagnose and manage vitamin D deficiency, while explaining potential analytical interferences that can affect the accuracy of the test results. Finally, we will discuss how to interpret those results and provide strategies to address deficiency through lifestyle changes and supplementation. Whether you're a medical student, healthcare professional, or just curious about this essential nutrient, this video will provide a comprehensive understanding of the science behind vitamin D and its far-reaching impact on health. The discovery of vitamin D began in the 17th century and is tied closely to the history of rickets, a debilitating bone disease in children characterized by soft and deformed bones. As the populations moved from the farms to the cities during the Industrial Revolution, a higher incidence of rickets was noted, especially in polluted areas with limited sunlight. Physicians began to investigate the link and discovered that exposure to sunlight and treatment with cod liver oil appeared to cure and prevent this debilitating condition, leading to the investigation of a nutrient linked to bone health. However, it was only in the 1920s that a substance in cod liver oil was identified as vitamin D2, and further research uncovered both vitamin D2 and vitamin D3, highlighting the important link between sunlight, nutrition, and overall health. Interestingly, what was initially called vitamin D1 was later discovered to be a mixture of vitamin D2 and lumisterol that was originally identified in cod liver oil, and the term was eventually abandoned. This left vitamin D2 derived from plant sources and vitamin D3 produced in the skin upon exposure to sunlight as the two recognized forms of vitamin D. Vitamin D, as mentioned, exists primarily in two forms: D2 or ergocalciferol and D3 or cholecalciferol. Vitamin D2 is synthesized by fungi and microalgae and is found primarily in plant-based foods like mushrooms and fortified products. Vitamin D3, on the other hand, is synthesized in our skin when exposed to sunlight and can also be found in animal-based sources such as fatty fish, egg yolks, and liver. The production of vitamin D3 begins when ultraviolet B radiation between 280 and 320 nanometer wavelength hit the skin and break open the B ring of the molecule 7-dehydrocholesterol to form a substance known as pre-vitamin D3. Pre-vitamin D3 then undergoes thermal isomerization, a process driven by body heat, and is converted to vitamin D3, also known as cholecalciferol. Once in the bloodstream, whether obtained from food sources as vitamin D2 or synthesized in the skin as vitamin D3, it binds primarily to vitamin D binding protein and is transported to the liver. In the liver, vitamin D is hydroxylated by 25-hydroxylase enzymes forming 25-hydroxyvitamin D, also known as calcidiol or calcifidiol. This is the predominant circulating form of vitamin D in the blood, which is also the form that is commonly measured in the laboratory to determine vitamin D status. The 25-hydroxyvitamin D is then further hydroxylated by 1-alpha hydroxylase enzymes in the kidneys to form the biologically active 1,25-dihydroxyvitamin D or calcitriol. This conversion is tightly regulated by parathyroid hormone, blood calcium and phosphate levels. In states of hypocalcemia, low calcium, or hypophosphatemia, low phosphate, PTH stimulates 1-alpha hydroxylase activity, increasing calcitriol production. Calcitriol, or the active form of vitamin D, then acts to enhance intestinal calcium and phosphate absorption, maintain bone health, and regulate mineral balance. The system also features a negative feedback loop. Elevated calcitriol levels inhibit further PTH release, thus reducing its own production. In addition, fibroblast growth factor 23, produced by osteocytes, downregulates 1-alpha hydroxylase and promotes the expression of 24-alpha hydroxylase, which catalyzes the conversion of both 25-hydroxyvitamin D and calcitriol into their inactive metabolites, such as 24,25-dihydroxyvitamin D and 1,24,25-trihydroxyvitamin D. These inactive metabolites are then excreted in bile and urine, ensuring tight regulation of vitamin D homeostasis. The regulation of calcitriol production is critical not only for calcium and phosphate homeostasis, but also for the suppression of PTH secretion and prevention of hypercalcemia, or high calcium in the blood. Vitamin D is well known for its role in maintaining calcium and phosphate homeostasis to support bone health, but research has revealed its wide-reaching effects across multiple biological systems. The active form of vitamin D, 1,25-dihydroxyvitamin D or calcitriol, has both calcemic functions regulating blood calcium and phosphate levels and non-calcemic functions, including roles in immune modulation, cell differentiation, and even cardiovascular health. Let's first look at the calcemic function. Calcitriol, the active form of vitamin D, is crucial for maintaining calcium and phosphate balance, which is essential for bone health and various physiological processes. It enhances calcium absorption in the intestines by increasing calcium-binding proteins, ensuring sufficient calcium for bone mineralization and physiological processes like nerve transmission and muscle contraction. In the kidneys, calcitriol promotes calcium reabsorption, reducing urinary loss. Together with parathyroid hormone, it stimulates bone resorption when blood calcium is low, releasing stored calcium and phosphate into the bloodstream. Additionally, calcitriol enhances phosphate absorption, contributing to bone strength and cellular functions. Let's now go through the non-calcemic effects of vitamin D. Vitamin D has significant impact on both the innate and adaptive immune systems. It enhances the pathogen-fighting ability of monocytes and macrophages and decreases inflammation. It also modulates the adaptive immune system, helping to maintain immune tolerance and preventing overactive immune responses, which can contribute to autoimmune diseases such as multiple sclerosis and type 1 diabetes. Vitamin D also promotes the production of antimicrobial peptides, which help fight infections. Vitamin D deficiency has been linked to cardiovascular diseases such as hypertension, heart failure, and atherosclerosis. While the exact mechanisms are still being studied, research suggests that vitamin D affects vascular smooth muscle cell function and modulates the renin-angiotensin-aldosterone system, which regulates blood pressure and fluid balance. By suppressing this system, it can reduce hypertension and cardiovascular risks. Epidemiological studies suggest that higher vitamin D levels are associated with a reduced risk of certain cancers, such as breast, prostate, and colon cancer. In vitro and animal studies show that vitamin D may help inhibit tumor growth by promoting cell differentiation, reducing cell proliferation, and inducing apoptosis or programmed cell death. Vitamin D has a direct effect on muscle cells, improving muscle strength and function. Adequate vitamin D levels have been associated with reduced risk of falls in the elderly as it helps maintain muscle tone and balance. Vitamin D receptors are present in skeletal muscle cells, and the activation of these receptors promotes muscle growth and repair. Emerging research links vitamin D deficiency to mood disorders such as depression and anxiety. Vitamin D receptors are found in brain regions that regulate mood, and its role in synthesizing neurotransmitters like serotonin may explain its influence on mental well-being. Low vitamin D is also associated with a higher risk of seasonal affective disorder and depression. Vitamin D plays a role in glucose metabolism, potentially improving insulin sensitivity and reducing the risk of type 2 diabetes. Studies suggest that it enhances pancreatic beta cell function, which is critical for insulin production, and deficiency has been linked to insulin resistance and a higher risk of developing metabolic syndrome. In addition to its role in reducing inflammation, vitamin D has been found to influence the risk and progression of autoimmune diseases. By modulating T-cell responses, vitamin D reduces the risk of autoimmune attacks on body's own tissues, which is relevant in conditions like lupus, rheumatoid arthritis, and inflammatory bowel diseases. Vitamin D deficiency is a widespread issue affecting populations across the globe. Various factors such as geographic location, skin pigmentation, indoor lifestyles, and cultural practices contribute to this condition. An estimated 1 billion people globally suffer from vitamin D deficiency, with approximately 50% of the world's population having insufficient levels of vitamin D. Without intervention, this deficiency can lead to significant health complications. Population at risk includes people living in northern latitudes with limited sun exposure, especially during winter months, individuals with darker skins as higher melanin levels reduce the skin's ability to produce vitamin D, older adults whose skin's ability to synthesize vitamin D and renal function decline with age, people with conditions that affect fat absorption such as celiac disease or Crohn's disease, as vitamin D is a fat-soluble vitamin. As you can see from the table, vitamin D deficiency is a global health crisis. Severe deficiency in vitamin D can lead to numerous health complications, ranging from bone disorders to immune dysfunction. This table summarizes the primary conditions caused by insufficient vitamin D. Just to summarize, in children, severe deficiency causes rickets, characterized by bone deformities, growth retardation, and soft bones. In adults, it leads to osteomalacia, resulting in weak, painful bones and an increased risk of fractures. Chronic deficiency is also linked to an elevated risk of osteoporosis, impaired immune function, and increased susceptibility to infections, autoimmune disorders, and chronic diseases like diabetes and cardiovascular disease. Vitamin D testing is critical in various clinical situations to assess and manage potential deficiencies or disorders related to vitamin D metabolism. The main indications for vitamin D measurement include bone health concerns, diagnosing and monitoring conditions such as osteoporosis, osteomalacia, and rickets. Bone high-risk groups, elderly individuals, those with limited sun exposure, people with darker skin, and individuals living in higher latitudes. Chronic kidney disease. Monitoring vitamin D status in patients with impaired renal function is important, as kidney disease can affect vitamin D metabolism. Malabsorption disorders. Conditions like Crohn's disease, celiac disease, or patients post-bariatric surgery may have impaired vitamin D absorption requiring close monitoring. Hyperparathyroidism, to assess calcium and phosphate metabolism in individuals with hyperparathyroidism. Pregnancy, ensuring adequate vitamin D levels to support maternal and fetal health. Autoimmune diseases, testing is valuable in autoimmune conditions including multiple sclerosis and lupus due to vitamin D's role in immune regulation. Accurate measurement of vitamin D levels is crucial for determining vitamin D status, diagnosing deficiency, and monitoring treatment. The measurement of vitamin D has evolved significantly since its discovery. Initially, vitamin D status was assessed through dietary intake and clinical symptoms rather than laboratory measurements. The first chemical methods for measuring vitamin D levels emerged in the 1940s, with the development of bioassays using rats to evaluate its effect on bone health. In the 1960s, radioimmunoassay techniques began to be used, allowing for more precise measurements of vitamin D metabolites. Over the years, advancements in technology have led to the development of various analytical methods, including other types of immunoassays, high-performance liquid chromatography, and mass spectrometry, which are now considered the gold standards for vitamin D measurement. These methods have both advantages and limitations. Let's briefly go through each one. Now, the early methods for measuring vitamin D were primarily biological assays and chromatographic techniques. These early biological methods assessed vitamin D's efficacy by observing its effects on the growth of rickets-susceptible animals. While they provided a measure of biological activity, these assays were time-consuming and less precise. Developed in the 1940s, TLC allowed for the separation of vitamin D from serum lipids. Samples were extracted with organic solvents applied to chromatographic plates and visualized under UV light. This method, while innovative, had limitations in specificity and accuracy. HPLC is another chromatographic technique used to separate, identify, and quantify vitamin D metabolites. It involves passing a liquid sample through a column packed with a stationary phase where different vitamin D compounds are separated based on their chemical properties. The separated metabolites are then detected, often by ultraviolet absorption, and quantified. One of its primary advantages is its specificity, as it can differentiate between various vitamin D metabolites, including both D2 and D3 forms. Additionally, HPLC is highly sensitive, capable of detecting low metabolite concentrations, which makes it valuable in both research and certain clinical applications where precise measurements are essential. However, HPLC has limitations that impact its routine clinical use. The process is labor-intensive, with sample preparation and analysis often requiring more time compared to automated techniques. This method also demands a high level of expertise. Consequently, HPLC has largely been phased out for routine clinical testing, replaced by more efficient techniques like liquid chromatography tandem mass spectrometry, which offer faster processing and greater automation capabilities. Today, liquid chromatography tandem mass spectrometry is considered the gold standard for vitamin D measurement in clinical laboratories. This method combines liquid chromatography for separating vitamin D metabolites and tandem mass spectrometry for detecting and quantifying them. It can measure both 25-hydroxyvitamin D2 and D3, as well as other vitamin D metabolites with high precision. This method provides high sensitivity and specificity for detecting multiple vitamin D metabolites and demonstrates minimal interferences from other serum components, making it particularly reliable for precise measurements. Additionally, LC-MS can measure various forms of vitamin D in a single analytical run, enhancing efficiency in comprehensive vitamin D analysis. However, the method does come with some limitations. LC-MS requires expensive equipment and highly skilled personnel, which can be a barrier for some laboratories. Furthermore, the sample preparation process is often longer than that of immunoassay techniques, which can impact turnaround times for high throughput settings. Historically, radioimmunoassay was one of the first methods developed to measure vitamin D. It uses radioactively labeled vitamin D to compete with the patient's vitamin D for binding to specific antibodies. The radioactivity of the bound complex is then measured, which is inversely proportional to the concentration of the vitamin D in the sample. Due to the strict regulation and safety risks of handling radioactive isotopes, other types of safer immunoassays such as enzyme-linked immunosorbent assay and chemiluminescent immunoassay became more common. These methods also utilize antibodies that specifically bind to vitamin D metabolites, providing a quantifiable measure. Immunoassays offer several advantages for vitamin D testing, making them popular in clinical laboratories. They allow high throughput and deliver relatively quick results, which is especially beneficial for routine screening in high-volume testing environments. Immunoassays are also more cost-effective and user-friendly compared to chromatographic methods, allowing for easier implementation in various clinical settings. However, they have some limitations, including susceptibility to cross-reactivity and interference from other compounds in the sample, which can affect the accuracy. Additionally, their sensitivity can vary, particularly when measuring low concentrations of vitamin D, which may limit their reliability in specific cases. Just a side note, I do have a separate video where I explain the principles behind various immunoassay techniques which are widely used today to detect and quantify a range of biological analytes. You will find the link in the description and I highly recommend watching it. In clinical laboratories today, immunoassays remain the most used method for routine vitamin D testing due to their automation, cost effectiveness and short turnaround time. However, liquid chromatography tandem mass spectrometry is increasingly utilized, especially for patients with complex conditions or those requiring highly accurate differentiation between vitamin D metabolites, such as those on vitamin D2 therapy. It's therefore the gold standard when specificity and precision are critical. In addition, LC-MS may be more appropriate for the following patients: patients on vitamin D2 supplement, patients with chronic kidney disease, patients with granulomatous diseases, pregnant and lactating women, patients with rare metabolic disorders, patients on long-term steroid therapy, and patients with severe liver disease. Several factors can interfere with vitamin D test results, particularly in immunoassays. Cross-reactivity. Immunoassays may detect other vitamin D metabolites or compounds that are structurally similar, leading to over- or underestimation of vitamin D levels. Lipemia or hyperbilirubinemia. Lipids or high bilirubin can interfere with some immunoassays by affecting optical measurements, leading to inaccurate results. Hemolysis. Hemolyzed blood samples can release intracellular components that interfere with test reactions, particularly in immunoassays. Medications. Certain medications like steroids, anticonvulsants, and antifungal drugs can affect vitamin D metabolism and consequently affect the results. For instance, glucocorticoids can inhibit vitamin D metabolism, while anticonvulsants such as phenytoin induce enzymes that accelerate its degradation. Given the potential for interferences, liquid chromatography tandem mass spectrometry is preferred for its superior specificity, as it can differentiate between vitamin D2, D3, and other metabolites with greater accuracy. Interpreting vitamin D test results is essential for assessing an individual's vitamin D status and guiding clinical decisions. Vitamin D levels are typically measured as 25-hydroxyvitamin D or calcidiol, which is the primary circulating form of vitamin D in the blood and best reflects overall vitamin D stores. As you can see, vitamin D results can be produced in nanograms per mil or nanomoles per liter. A vitamin D result less than 20 nanograms per mil or less than 50 nanomoles per liter indicates deficiency. A vitamin D result between 20 to 30 nanograms per mil or between 50 to 75 nanomoles per liter indicates insufficiency. An optimal vitamin D level falls between 30 to 50 nanograms per mil or 75 to 125 nanomoles per liter. A vitamin D level that is greater than 150 nanograms per mil or greater than 375 nanomoles per liter indicates toxicity. This can cause hypercalcemia or high calcium in the blood, kidney damage, and soft tissue calcification. When interpreting results, it's crucial to consider the analytical methods used, such as immunoassay or liquid chromatography tandem mass spectrometry, as these may affect the accuracy and specificity of the measurements. LC-MS offers higher precision and is preferred in cases requiring greater specificity. To correct vitamin D deficiency or insufficiency, a combination of sunlight exposure, dietary sources, and supplementation is recommended. Sunlight exposure is the most efficient method to increase vitamin D levels. Spending time outdoors, particularly during midday, stimulates vitamin D production in the skin. Individual factors like geographic location, skin type, and age affect sun exposure needs, making personalized recommendations essential. When considering sun exposure as a method to boost vitamin D levels, it is also essential to understand the role of sunscreen, not only for skin protection, but for its potential impact on vitamin D production. Research indicates that high SPF sunscreens can block the UVB rays required for vitamin D synthesis in the skin, potentially affecting vitamin D levels. However, studies also suggest that partial or inconsistent sunscreen application may not significantly hinder vitamin D production. A balanced approach, such as brief, regular sun exposure on areas without sunscreen, alongside proper sunscreen use on high-risk areas, can help support vitamin D levels while protecting skin health. Foods rich in vitamin D, including fatty fish, fortified dairy, egg yolks, and UV-exposed mushrooms, can contribute to maintaining adequate vitamin D levels. However, for many, diet alone may not be sufficient, especially for those with limited sunlight exposure or higher requirements due to health conditions. For most individuals, supplementation with vitamin D3 or cholecalciferol is preferred over vitamin D2 because D3 is more potent and effective at raising vitamin D blood levels. For those with dietary restrictions, such as vegans, vitamin D2 can still provide benefits, though it may require higher or more frequent dosing. Emerging research indicates that calcifidiol, or the 25-hydroxyvitamin D, may provide a more rapid correction of vitamin D levels than traditional D2 or D3 supplements. This is because calcifidiol is the 25-hydroxylated form of vitamin D, which bypasses the slower liver conversion step required by D2 and D3. As a result, it enters the bloodstream ready for use, needing only further hydroxylation in the kidney to become the active form calcitriol. This makes calcifidiol especially useful in clinical settings where rapid correction of vitamin D is necessary. For instance, ICU patients, particularly those suffering from critical illnesses like sepsis or respiratory failure, often present with low vitamin D levels. Timely correction of vitamin D deficiency is thought to be beneficial in such settings because of vitamin D's role in modulating the immune response, reducing inflammation, and enhancing recovery from acute illnesses. Research suggests that ICU patients with higher vitamin D levels have improved outcomes such as better respiratory function and shorter stays in the intensive care. While not commonly prescribed worldwide, calcifediol is available by prescription in several countries, including Spain, Italy, and the United States, where it's used particularly in patients with severe vitamin D deficiency or in conditions where rapid restoration is required. Health guidelines vary slightly across regions, but in the US, a daily intake of 600 to 800 international unit is recommended for adults, with higher doses up to 4,000 international units considered safe for addressing insufficiency. In Europe and Australia, similar guidelines apply, though some patients may require even higher doses, particularly during winter months or if their deficiency is severe. Clinicians often prescribe 1,000 to 2,000 international units per day for moderate deficiency, but doses can reach up to 10,000 international units in more severe cases, typically under medical supervision. Supplementation needs to be tailored to each individual's requirements based on factors like age, pre-existing health conditions, and their current vitamin D levels. Monitoring is crucial to prevent toxicity, as excessive vitamin D can lead to hypercalcemia, high blood calcium, which poses serious health risks. Therefore, healthcare providers should carefully guide supplementation strategies, balancing sunlight exposure, dietary intake, and appropriate dosing of supplements to restore and maintain optimal vitamin D levels. To summarize, vitamin D plays a crucial role not only in bone mineralization, but overall health. With deficiency rates alarmingly high worldwide, proper testing, accurate result interpretation, and personalized supplementation strategies are essential for maintaining optimal health. By addressing insufficiency early, healthcare professionals can prevent severe complications and promote long-term wellness in their patients. With that said, thank you for watching. I hope you found this video helpful. See you in the next one.